Good morning, everyone, and thank you for joining us today. My name is Sean Moore from the Community Anti-Drug Coalitions of America. We're conducting a webinar today on SBIRT implementation, what prevention professionals can do to start the implementation process of SBIRT services. And our webinar today is going to be led by Christina Boyd. You could go ahead and advance that slide, Christina. The webinar is presented as part of the Opioid Response Network, and this is a grant that's been set up by SAMHSA to work with individuals and other organizations at a local level and help share resources and technical assistance that these communities need to work in the opioid epidemic. It is a technical assistance platform providing evidence-based services related to prevention, treatment, and recovery of opioid use disorder. You can submit a technical assistance request on this website, the opioidresponsenetwork.org. We are a request-based service, so please let us know how we can help you, how we can work with what your organization needs. And of course, you can start that conversation by emailing the Opioid Response Network at AAAP or calling AAAP directly. The American Academy of Addiction Psychiatry is the leader of this amazing grant that SAMHSA's set up. Of course, funding for this initiative was made possible by that federal grant from SAMHSA, and the views expressed in the webinar today, both my own and those of Christina, our host, will not necessarily reflect the Department of Health and Human Services or the US government, and we will not be endorsing any products. Our approach working with the Opioid Response Network is not to recreate the wheel, but to help network local resources, help identify what resources are available in a community, and fill any gaps, strengthen any organizations that we're able to work with. Christina, could you advance? And again, we're providing training and technical assistance related to all things prevention, treatment, and recovery of opioid use disorder. For today's webinar, just a few quick housekeeping notes. By default, you are muted. I'm actually not going to be unmuting participants during the webinar. So please do make the best use of this Q&A chat box that you see towards the bottom right of your screen. This is where you can ask a question, and we'll be coming back to those questions at the end of the webinar. I don't personally make use of the raise hand function, but if you'd like to send a chat to the entire group, that's possible via the chat box. You'll see the chat box will make a note who you're sending a message to. It'll probably say all attendees, and that's how you know you're sending a general audience chat. So please do make use of that Q&A button. Christina, could you go ahead and advance? Please do send me an email. My name is Sean Moore. I'm the manager of special projects and initiatives at CADCA. If you have any questions about upcoming Opioid Response Network prevention webinars, if you'd like specifically to be notified whenever we schedule a new webinar, that's a list I maintain. And for all attendees today, I'll be circling back with a PDF of today's webinar so that you can get all of the resources and slides, all the references that you might not be able to catch while we're doing the webinar live. Our speaker today is Christina Boyd. Christina's a clinical social worker as well as a clinical addictions counselor who's worked in the behavioral health field for more than 22 years. She's currently the Western Kansas MSW Program Director for the University of Kansas School of Social Welfare, and she is the CEO of a behavioral health and consulting company, Hope and Wellness Resources. Christina is an experienced SBIRT trainer and has provided live and virtual presentations on the implementation of SBIRT into medical settings throughout the country. She continues to reside in Western Kansas, and she's passionate about equity of health resources in rural areas. So without any further ado, I want to kick it over to Christina, and I'll speak to you more towards the end of the webinar.
Okay, thank you, Sean. Welcome, everyone. So glad you could join us today. We are going to be talking about SBIRT implementation and some of the things that we can do as communities, and then from the prevention side when we really look at SBIRT, because that's what it is. It's all about prevention. So a quick agenda for those that love agendas to reduce some anxiety of what we're going to be talking about today. I always like to start with the why. This is a really good implementation point in general, whatever population we're talking with. It's very important that we relate making changes, because this is all about maybe changing the conversation that we've been having. Looking at that why is a really important step. We don't want to skip over that. So we'll look at a few of the reasons why today. We'll do just a very, very brief overview of SBIRT. Hopefully folks were able to join us last week when we went more in depth into what SBIRT really is, as far as the screening, brief intervention, and referral to treatment services. We'll talk about how we can start to implement a lot of resources. I think it's important to know what's out there. So again, as was mentioned earlier by Sean, that we're not trying to invent things that may already be out there. We'll have a little bit of time for questions and then wrap up. So that's how our focus will be for the next hour. So why SBIRT? As I mentioned, always a good place to start. We want to connect the why for people and individuals in our community. So why SBIRT? I often challenge everyone at the very beginning of any training I do is to think about how these services could benefit the people that you're here to help. And really starting to consider how this could work in our communities. I know sometimes we get caught up in the why maybe it wouldn't work. So if we can take some time just for the next hour to suspend that disbelief and really keep our minds open, that would be great. So some of the why. We know some of this may be information that you already have heard or are aware of, but just briefly to go over. In 2017, the CDC estimated that on average about 130 Americans were dying every day from an opioid overdose. We're seeing numbers continue. Different stats, you may see different numbers, but I think we can all agree that this is a crucial time in our country, and that the opioid epidemic really is something that we need to be addressing in all the quadrants. So not only in treatment, recovery, but also in prevention. The estimated cost, NIH had estimated that over $820 billion was being spent on different aspects of healthcare overall for many different substances. That's really hard to even conceptualize when we get into the billions, how much we're talking about the costs of that in our society. Also keeping in mind just that the health, our overall health and wellness, that substances do have an effect on our health, and it's important. That's a big piece of what SBIRT is, in that screening and that brief intervention that we're doing with individuals, that we're really relating it to health and giving people good information about how substances affect their body, because they may not be aware, so that they can then make an informed decision about what substances they are taking in. So I will show you where to find some of these resources that I'm showing here. These are great handouts for not only some training purposes, but also to give to individuals. And I'll show you where to find those here in a bit. So SBIRT, again, just a brief overview. It really is about prevention. We're really looking at encouraging universal screening, that everyone gets screened, not just individuals who've come in with an identified issue, that we're really recognizing that if we can intervene earlier in the process, the better the prognosis down the road. And that, I used the analogy on our last webinar about the fire. And really, again, substance use, the opioid epidemic, we're really seeing this fire really, again, if we were to equate that to kind of like a wildfire right now. It's really hard to contain. It's really complex and difficult to address. And so we're really seeing the need for prevention. to really be able to affect outcomes in the long run. We've got to start looking at prevention measures and starting earlier and earlier. So with that screening, again, it's universal. We're identifying from that universal screening those that test positive, that need a more full or targeted screen, and then doing a brief intervention to help individuals understand their substance use and the impact, again, on their health. And then a key component of this is motivating behavioral change. So just a quick plug here for our next seminar, or our next webinar. We will be going more in depth into that brief intervention and the skills used during that, because it can be very helpful in a lot of different areas. But really that motivating towards change, again, the why for individuals about why they want to make a change in their life, either whether that's reducing or stopping use, or taking a referral on to more intensive treatment. That referral to treatment portion of SBIRT services is really to help individuals, patients, clients, participants who are showing signs of a possible substance use. It's not meant to be a diagnosis, but really to assess risk. So if there's a high risk there for a substance use disorder, it's again doing a brief intervention to motivate change towards taking that referral, in ways that we can do that with a warm handoff and other tools to ensure that people are getting the help that they need. Because we do know that even when identified, still a small percentage of people are accessing care that they need for a lot of different reasons. SBIRT, just to keep in mind, it really does target about the 20% when screened in primary care settings, about 20% of the U.S. population that uses substances at a risky or harmful level. Again, this is all about risk. It's to identify and effectively intervene with those individuals, and to, again, relate if they're having any psychosocial or healthcare issues, relating that to their substance use, and then again motivating towards making changes. So we're going to talk again, and this is part of that why SBIRT. Why do you hear so much maybe about that here recently? We're starting to see a lot of benefits of using these set of services when they're done correctly, when the implementation happens very mindfully and purposefully, that it really can have an effect on outcomes. And so that's what we're going to focus on today, is that implementation process. We've seen about a 47% reduction in new injuries requiring ER treatment for those that have received these set of services. And this is all based on SAMHSA, Substance Abuse Mental Health Services Administration. They've had several cohorts over the last decade or so that have received funding to implement SBIRT services, and then they were able to collect data from all these different areas. And these are some of the outcomes that resulted from those cohorts. We saw 48% reduction in new injuries that required a hospital admission. Those out there in the prevention community, this is not going to be shocking, I don't think, but go ahead and sit down anyway. But for every $1 spent on SBIRT, approximately $3.81 was saved. So again, we know that prevention works, that if we spend that money on the front end, we may reduce some of the damage or impact of some of these disorders in the long run. And so, again, if we're talking dollars and cents, if we want to start having an effect on those billions of dollars that we're spending each year, we've got to do something different. We need to change this conversation. Patients recommended for brief therapy and referral to treatment reported significant improvements in general health, mental health, employment, and housing status. So this all comes from the TAP number 33, which we're going to go into a little more in depth, some of the aspects of that. Again, we want to use the resources out there. SAMHSA spent a lot of time gathering this information and have bundled that into a really nice guide, which we're going to talk about. So this is TAP 33. This is available free to download. You can find it if you just type in Google, the Google machine, SAMHSA TAP 33. You can go to the website. Excuse me. Sometimes it's available in a hard copy. I've been able to get a few hard copies, although I would say that's becoming more and more rare. But again, always available to be downloaded, and then you can always print it or keep it in that digital version. So we're going to talk about TAP 33 and go into some of the resources that I think may help to support these different areas. So one of the first areas that TAP 33 recommends is before we start handing out that very first screen, we need to make sure that we have some things in place. We can note that sometimes not having good preparation, training, competency of those providers who are presenting these set of services can actually do some harm if people aren't met with a non-judgmental space, a safe space to talk about these things. If follow-up is not provided, referrals aren't available, a myriad of things. And so we want to make sure that we do a careful assessment first. Part of that may be we want to look at both our physical space, our personnel, looking at can we provide these services with our current staffing. Again, in communities, this may be part of that initial awareness about SBIRT. I could see coalitions and have been part of coalitions where being able to provide some support, some information about TAP 33, getting this conversation started with agencies that might be willing to look at implementation of SBIRT. This is a place to start. Another area is around training. Training is definitely going to be needed in a lot of different agencies or system delivery where individuals may not be accustomed to having these types of conversations, talking about substance use, looking at it in this way. And so training is another area where coalitions may have a huge impact. I've lived in communities where the coalition actually supported and helped to coordinate and facilitate different trainings being offered to community partners. That sort of thing. So that might be something to think about as you move forward. What SBIRT services require new hiring? So again, within agencies, depending on your state regulations, it may be more prescribed, especially if SBIRT services sometimes in some states are billable, and there is an allowance to be able to bill for providing the screening, brief intervention, and that. And so what qualifications must those individuals have if that is the case in your state, or what would be needed or recommended depending on the setting that individuals are in. Space, we want to maintain confidentiality and privacy of individuals. And so will we have to have private areas or an area where individuals feel comfortable again in not disclosing information that's still somewhat stigmatized? Keeping in mind as we talk about this implementation process, a huge piece of SBIRT is, again, starting that conversation and starting to destigmatize this. Part of that, the purpose of having universal screening, for example, is about making it normal, normalizing that conversation, having statements like, we ask this of everyone because we care about your overall health and this is an important aspect of it. So this is another thing I think where coalitions can really have an impact on the effectiveness and the success of SBIRT services being delivered in their community. Also assessing the need for, how are we addressing stigma? How is that being addressed in our community? Are people willing to talk about this? Are there still some norms and cultural aspects around substance use that need to be addressed, again, more systemically? So within that, some resources out there I wanted to share. I'm going to go ahead and share where to find these just so you kind of have an idea. So again, around SAMHSA, I mentioned SAMHSA earlier. They have a whole, hopefully this has moved over and you're seeing that, a whole section of their website is dedicated to SBIRT. I wanted to point out here again those SBIRT grantees. Since 2003, again, SAMHSA has funded a lot of different cohorts. I think it's important if we're looking at different agencies providing support, there's a lot of information that came from these grantees. If you're looking at a college, for example, maybe medical professionals, different websites that are out there, Colorado, Oregon, they have a lot of information where, again, we can learn from what they've done. The other thing I wanted to point out here is the public messages. So again, knowing the risks of this gives examples of marijuana, meth, those kinds of things. So this might be a great resource where, again, we can utilize what's already been put together, kind of packaged, and then utilize that in our community to start addressing some of the, again, stigma, willingness of individuals to talk about this. Another site that's very, very good is SBIRT Oregon. It also lists on here some different information about workflow. So you can see here it gives adolescents, adults, adolescents, and then for those that are pregnant or may become pregnant, there's screening forms on here, there's video demonstrations, all of these things. There's even now a screening app, that's a new one. So you can, again, utilize, learn from individuals that have already implemented SBIRT into their services. Oregon is one of those states that's been doing it for quite a few years. They have some really good information there. The other thing I wanted to point out is UMKC, SBIRT. Also, there's also another website here, SBIRT.care. On here, there's a lot of patient education. So that's, again, where I was showing you earlier, those individuals' handouts. I love these because they're available in many different substances and also in many different languages. So those are super helpful. The other thing I wanted to point out was the training. Again, when we look at assessing, training is usually a key component of what's needed within agencies, communities. This is a free training that's available. It's available online. Individuals can go in. It's free online. You can go in here and click in. It's a 3.5-hour overview of SBIRT, and so that's available. Now there's others out there, but just wanted to, again, let folks know about some of these resources. The other thing available, this is from the get here. Okay, facilitate change. So this is from the National Council for Behavioral Health. It's a kit that they put together for adolescents, and so for doing SBIRT with adolescents. So there's again a lot of information here. I was trying to get here to the contents. We can talk about introduction. There's also talking about implementation considerations and things on here as well. So these are just a few of the resources out there. I'm going to go back to my PowerPoint here. But again, these are listed on here. You will, if you want to receive that PDF version, you can just simply click on these links. There's also a lot available through IRETA. They have online training, toolkits, and webinars. So this, again, may fit in when we do that assessment. Within our communities, within agencies, we may start to recognize some area of training that needs to happen. I think it's also important for communities to recognize the need that we may have different agencies, different entities that are looking to implement SBIRT. How can we kind of work together? And I think coalitions can be kind of a source of coordination so that we're not duplicating. If we have trainings, if we're supporting trainings coming in, individuals coming in and doing trainings in our community, that we're not, again, duplicating that. Could that have been one training and we had several different agencies attending? So making sure that we're making the most of our resources. If we have some funding around training or resources that are being devoted to that, how can we kind of share that with our community partners? And I think coalitions can be right at the hub of that in many cases. Another step that TAP 33 talks about is it's important to set clear goals. It's important to know what is to be accomplished within what time frame, having some direction within our communities around, again, if we're doing a campaign around awareness or reducing stigma, do we have a timeline for that and know who's responsible for what? Also being realistic. Sometimes this is a big shift, honestly, for a lot of agencies to start having these types of conversations in this way, to have training done, to have people bought it, kind of buying into why we're doing this. Sometimes it takes more time. I'm not a particularly patient person sometimes, and so that time frame I have to really work on being realistic about that and understanding and being patient to know it can take some time to truly implement SBIRT services effectively is going to take some time. And so just understanding that and setting some goals around that. Again, just some resources around that. If we're looking at an awareness campaign or stigma reduction, it's a great place to start. If people don't feel comfortable talking about these things, they may not be as valid, the answers they're given. We may not have open communication about that in those settings, and so that is, again, going to affect outcomes. We can look at posters. That's a great way to start to open up the conversation. It sends a direct message that it's okay to talk about it here. So having some of these, you can get these from SAMHSA, other entities out there. You can look and order those. I order these frequently when they're in stock. And maybe, again, something that coalitions can work to have someone that, maybe stockpiles these posters and then gives them out to community agencies, community partners, as a way to address awareness. I kind of got ahead of myself. This is that change package that I just showed you through the National Council for Behavioral Health that's available, that really targets youth. When we look at the imperative nature of prevention, we've got to start younger, and we need to be having these conversations often, and including our youth in that. And so this is, again, that change package that's available through the National Council for Behavioral Health that I showed you previously. It's interesting to note that the recommended screening age is now starting at age 9. Once again, the need to do that prevention, to make, and especially adolescents aware of the impact of their substance use, and starting that conversation much earlier than we may think. And so looking at ways that we can do that, again, is available through this package. Part of assigning clear roles and responsibility, TAP 33 talks about having individuals who are maybe coordinating that SBIRT effort may be helpful. This person could maybe make sure all staff members are understanding their roles and responsibilities, planning tasks, and completed. Once again, this might be something that within a coalition or a prevention community, we may identify an individual or a certain task force, someone that, again, could take this on to help coordinate this amongst either, and I'm seeing that we have a task force now in my state where individuals across the whole state are meeting virtually, every month or two to talk about resources, having some tasks planned out. So again, and that's really seen as a prevention measure. This is part of prevention. How are we getting the message out? How are we supporting people adapting and implementing SBIRT across the state? This could be pared down to, again, even community-wide, if we have coalitions that are functioning in a city or in a region or within counties. How could that support be there to help, again, know who is doing what, when, who's following up as they're reporting, if it's related to grant work, new training, how are we introducing this to new individuals that are coming into service delivery in our area. So again, assigning that clearly. Another aspect of this that we need to be aware of is special populations. As we're looking at setting those goals, we need to really be addressing, and this is, again, where some support for agencies that are looking at implementation, to have, sometimes we're looking at actually putting together some information around the policy implementation in agencies around confidentiality requirements, reporting measures, because it gets a little dicey when we're talking about, for example, pregnant women. What is the confidentiality? What is the reporting for mandated reporters when it comes to pregnant women, and also adolescents? This can get a bit murky, and we need to have this clarified before agencies start handing out that first screen. It's really important that we've identified how this is going to be handled within agencies. So there is, when it comes to pregnancy, this GUTTMACHER Institute, there's a website that outlines, depending on which state you're in, what are the requirements. And so let me take you quickly to that site. So here is the website, and it shows here substance use during pregnancy. They update this regularly. I believe this was in May of this year was the last update that I saw, but you can go through here and look at state policies. So for example, I'm in Kansas. I can look that substance use during pregnancy is not considered child abuse. It is not grounds for civil commitment. So again, you can look through this and determine where does your state fall, and all the states are listed there. So this is something that's very important for agencies to know about, to have policy around. What if they're going to be screening these special populations, they need to be aware of the reporting and confidentiality that surrounds that. So this is, again, just another resource. Also listed on there is teens. I think that's great. They're starting to look at that and expanding that. So this would be something that communities may need to work with their Department of Children and Families or child welfare agencies to really determine how these statutes, these regulations are being interpreted in their region, in their state. This is just a guide. I think it's always good to get some legal assistance in putting that together. And again, what a great resource for agencies if someone has kind of done some of that background within either a coalition, a task force, whatever the case may be, to already have answered some of these questions or have some consistency in how that's being interpreted. Another area, another step that TAP 33 recommends is developing collaborations and partnerships. Collaboration is critical no matter the size of the system, and I think that's such a great point. When I talk about SBIRT, when I go in with individual agencies and I talk about this topic, we oftentimes talk about that it's much too complex, and it takes way too much knowledge of all these different areas of prevention, treatment, recovery for one person to take that on. This really works best, SBIRT implementation works best when it's done as a team. And so that's where that collaboration, those partnerships are so key. And oftentimes, we don't have the luxury of providing all of these aspects of SBIRT, the screening, the brief intervention, and the referral to treatment, possibly the treatment, the recovery process, all of that under one roof. You know, some agencies are really becoming very integrated, and some of that is possible. If you live in rural areas, like where I live, that certainly is not something that can happen in most agencies. And so having this collaboration is very, very important. And so when we look at making that collaboration happen, again, coalitions, task force, community awareness, this is a great place to start connecting treatment providers, connecting resources, and helping in that integration. I often say SBIRT is a foot in the door to integration. We're moving more and more towards integrated services, identifying that behavioral health is part of health. I hope everyone again is sitting down. I'm going to say another shocking statement here, but our brains are part of our bodies. Yes, it's true. And so being able to recognize the need to collaborate more intensely to really affect outcomes is crucial. Another piece of this program, leaders should identify potential public and private collaborators and partners early on in developing these relationships. Again, if we're going to start handing out screens, we're going to start talking about brief intervention, we need to identify who are the treatment providers. Are there gaps? Oftentimes, and when I've worked with communities that start to really look at this implementation process, they identify gaps pretty early on. There may be gaps in treatment, there may be gaps in the referral system. So how can communities work together, again, advocate for for some of those services. Sometimes it does mean advocating for codes. That's something we're currently looking at within our state is, do there need to be some codes opened up so that some of these agencies that are working towards integration can really effectively provide those services because they want to underneath their own roof. And how can they, again, partner with other community partners to really to identify and address those gaps. And so one of the really crucial pieces of this, especially as we talk about opioids, we need to always be considering who needs to be at the table. So when we're talking about referral systems, I think it's very important that we also acknowledge that we need to have not only our traditional behavioral health services, which may include medication, talk therapies, case management, that sort of thing. Also recognizing with opioid use disorder, the absolute need to have medically assisted treatment be part of that referral, and having those individuals at the table when we talk about implementation strategies. How are we offering that we're not excluding the need for medically assisted treatment, especially around opioid use disorders. So this is a great little clip just kind of explaining what medically assisted treatment is. I know for many who maybe aren't in the treatment realm all the time may have heard of MET. Again, it's very prevalent in the literature as far as effective treatment. So I wanted to just quickly show this. And please, Sean, let me know. I'm gonna move this over, and hopefully everyone can hear it clearly. But let me know if there's any problems with the video. But this is about a 5-minute video I'm going to show real quick.
The neurobiology of addiction is a field that has really exploded over the last, let's say, 30 years. We are able to actually see what is going on in the brain in the addicted individual, the impact of the drugs that they are using on the brain, and then in some cases, the impact of some of the medications or pharmacotherapy that we use to treat their addiction. We can see improvement in brain function, which is very exciting. So as opposed to 50 years ago, when people thought that addiction was a problem of character or personality, or a criminal personality, or a weakness of will, or other ways of looking at addiction, we really look at it as a neurobiological disease, or to put that in simple terms, a brain disease. We all agree that addiction is a chronic disease, that it has currently no cure, but excellent treatments, and that remission or recovery, which I use synonymously, are goals that can be met by many patients through a variety of different treatments, including pharmacotherapy treatments and non-pharmacotherapy treatments.
There's several different options available for people that are looking for medication-assisted treatment, and it really depends on the underlying condition that they're suffering from. If they have a problem with alcohol dependence, they may be looking at options like naltrexone or antabuse. If they have a problem with opiate dependence, they may be looking again at naltrexone, but they also might be looking at methadone or Suboxone. The naltrexone is actually a blocker, and it both blocks the high people get from alcohol when they do that, and it actually also blocks the high people get from pain pills or heroin. Methadone is what's called a full agonist. You can look at the receptors in the brain as a door, and a full agonist opens the door completely into the brain, which allows the full activity of an opiate. And so methadone acts as a replacement therapy for opiates. So if someone's in withdrawal from heroin or pain pills, that's going to allow the full activity into the brain to replace that. But the problem with a full agonist is sometimes people can also have negative effects. There's risks of overdose. Buprenorphine, naloxone, or Suboxone is what's called a partial agonist. And that's like opening the door partway. And by opening the door partway, you're actually able to let enough in to help with withdrawal symptoms and cravings, but not so much where there's a risk of overdose or people look sedated or out of it.
Most of the evidence shows that if there is a pharmacotherapy which has been shown to be effective and to help with that addiction problem, that the use of that pharmacotherapy, in addition to the use of a variety of psychosocial treatments, such as one-on-one counseling or groups, or going to a mutual help group like AA or NA, that the combination of the psychosocial treatments along with the pharmacotherapy will usually provide better results than either one alone. I like to use the slogan that all treatments work for some people. No one treatment works for everyone.
Often people are reading online, so often they have an idea when they come into the office what medication is going to work best for them. And we have a discussion about it. What's right for them involves a lot of the, there's basic differences between these different options, and they would have to evaluate those differences on their own and then talk to a physician about these differences and kind of find the right fit for them.
One of the most common misconceptions and myths by both patients, but really more often significant others, and again, the mutual help groups, is that when you take buprenorphine or you take methadone, you're just replacing one drug with another. And this is just not true, because we're usually replacing a short-acting opioid, which is generally causing damage to the patient's brain, with a long-acting opioid, which is meant to normalize and stabilize the brain. And we actually have data now to support the idea that methadone and or buprenorphine will improve brain function. It is very important for the patient and their significant others to understand that physical dependence does not necessarily equal addiction. Let's take a patient who's on insulin for diabetes. They must take their insulin every day. If they don't, they get sick. But nobody ever says that they're addicted to insulin. They just say they're on insulin, they have to take it every day.
If you develop opiate dependence when you're 20, there's a very good chance you're not going to live past 40. So I would say that's deadlier than diabetes. That's deadlier than thyroid disease. So plus the loss of functioning, even with thyroid problem, diabetes, people can often make it to work. They can often go to school. With people with active opiate dependence, they can't do those things. There's a complete loss of functioning.
It's easy to withdraw people over a week, but to maintain the abstinence from non-prescribed or illegal drugs, that's the challenge, and that's where these medications come into play.
Okay, so I'm going to take this back here to the PowerPoint slide. Again, the reason I took this time, I think it is so important to understand, a little bit more about MAT, and again, the importance of that in the treatment process. I think this may be something that communities, task force, coalitions, prevention individuals might again be able to support more physicians in their communities becoming MAT certified, understanding the need for MAT assisted or medically assisted treatment. And so this may be an area where communities can support, raise awareness, even amongst physicians around, again, getting the certification. They've now made this easier to obtain, the ability to be able to prescribe these medications. And so, again, even just, again, awareness in our communities and our 12-step groups, whatever, around, so we can identify routes for this to happen more and more in our communities. I know, again, I live in a rural area, and so there is the need to be able to identify individuals in our communities because we just don't have enough that are physicians that are able to prescribe. So something else to think about as we look at implementation processes. This is a gap that often gets identified in different areas and communities, and so we have to think of creative ways, again, to bring awareness to this, to support this within our communities as we move forward. Some lessons learned. This is again from TAP 33. This was learned from different SBIRT grantees. They kind of compiled this into some concrete lessons. We want to always look at our implementation in ways that minimizes the burden, the time burden for staff. So again, I often say this needs to be integrated into what we do already, not something in addition, because if it's something in addition, then oftentimes it may fall off. And so being able to find ways that we can integrate into either a health assessment that's already being done, an intake that already happens. Something that we do already is very important. We want to develop strong champions of SBIRT. I definitely see within my state that I live some very strong champions of SBIRT that have really helped to bring this along. And again, having them in different domains and different communities, being able to support implementation process is going to be an important piece. Provide time for staff to buy into these activities. Again, the why that I mentioned earlier, that is so important. I can't stress that enough. We can skip on over to the how, and we can have the best laid out plan ever. But if people don't understand why this is important, how it helps them, how it benefits their population that they see, sometimes we don't see the outcomes improve as much. And so we definitely want to get that time for the why. Training, ongoing supervision and monitoring, and regular feedback. Again, this may come into play in prevention communities if we've maybe assisted in finding a grant to help with implementation. We want to make sure that, again, the training is adequate. There's regular feedback. How are we helping to support, again, maybe that grant process within our community. Institute SBIRT training as a regular part of employee orientation. So again, this addresses the issue that we do have turnover. We have people, coming into our communities, leaving our communities. How are we really making this part of just service delivery overall? That these are conversations we have in our community. It's okay to have them. We're open to it, all of those things. So how do we really integrate that in a way that is sustainable? You'll hear that word. I'm sure those that have worked with grants, that's not a new word, right? Sustainability. We always want to be looking at sustainability with any of these services. We want to collect and share aggregate and patient level outcome data so that the staff members can see how they help, the help that they provided to the patients or participants. So again, we can relate this over to community-wide. How are we collecting? How are we sharing that data? Are we identifying areas that we're really wanting to affect, and are we having an effect on those areas community-wide? So this would all be part of that implementation. How are we developing that mechanism to begin with? We can also combine SBIRT with other behavioral interventions. I'll talk about in the next session that we have around, these services, these skills that we use in the brief intervention are really good with human beings. And so recognizing that we may be able to train individuals on that motivationally enhanced brief intervention or brief negotiated interview, it works well with a lot of different behavioral changes. So it's really about change, how we help support and motivate people to make changes. And so it really is applicable to a lot of different areas in the change process. So I would encourage you, I know I think maybe have some questions. I see some things popping up on chat. So I would challenge you, before we kind of get to that question portion here, to think about what is one thing you could do. And maybe if you feel comfortable, go ahead and put that in the chat. What would be your first step? What could be one thing you could do to help support SBIRT implementation in your community, in your agency, in your state? What is one thing that you could do, kind of from looking at it from that prevention side, that you could take that one step forward? So I'm going to leave just about 1 minute here for folks to maybe type that in chat. Just how would you start? So hopefully folks are at least thinking about it. Again, if you're not comfortable putting in chat, that's fine. But again, just recognizing it may be something, it's one thing to hear about it. What do we do with the information, right? Always. So I think we have time for some questions, Sean. I do notice I think there was one here in the question and answer.
So the question in the box is a great one. We're really interested in implementing SBIRT, but I've never done it before, right? And I've started this conversation with local clinics and schools, and they in turn are interested in implementing SBIRT, but they're also apprehensive because they're looking at me, they see that I don't have the experience having set up this program before. So who can I reach out to? What are the forms of local technical assistance to help coordinate a local SBIRT pilot, help get that off the ground initially?
Great question. So, and it looks like Michael maybe had to get off, but I'm taking down his information to maybe shoot him an email. But I think, what the very first thing comes to mind is this opioid response network that is set up specifically to provide TA training support. They have experts across the United States. They're able to find people either regionally or that are willing to provide some technical assistance as part of this program that's providing this webinar here today. So that would be one way to get some technical assistance. I think, again, you're not alone, and hopefully through this also recognizing some other resources out there. Michael had mentioned in the chat here in the question of maybe reaching out to someone who was about an hour away, so hopefully maybe that's in the same state, and to have some questions there, maybe how they were able to do it. I think that's always a great way to start, is to find individuals either in your region, in your counties, in your state that are implementing these services, and to maybe, just talk with them about what's been helpful. Has there been assistance? I'd be very interested to know which state he's in. The other thing I would say is that a lot of states also are providing, like SBIRT Oregon. There's different, again, that UMKC is providing services or support around SBIRT implementation in Missouri and Kansas. The ATTC, so if you're not familiar with those, I'm going to put that, if I can here. I don't know if I can get to my chat. I don't know if, go ahead, Sean.
I can chat it out to the group.
Okay, perfect. So the ATTC network, which is the Addiction Addiction Technology Transfer Centers. Every state belongs to a region, and a lot of them are doing work around SBIRT right now, or have, again, maybe some funding, some TA support that they might be able to provide. So I would say those would be two national places that would be a great place to start. And then again, I will follow up with Michael and find out maybe a little more information where he's coming from as well. So I am taking that down. Let's see, did we have Sean, any other questions that came in maybe through the chat?
I am seeing a couple examples in the group chat of first steps we can take. Would you like to hear those, or move on to the questions we had prepared?
No, I think that's perfect. If folks have some input, that'd be awesome.
So Phyllis is sharing that perhaps she'd like to rally the coalition members and start assessing or educating certain partners in the community. So I'm thinking she's prioritizing sort of key stakeholders.
Awesome. I think that's a great start, Phyllis. Again, that partnering, raising awareness, all of that is a great place to start.
And then we have a chat from a city leader talking about dealing with community poverty. She'd like to start the conversation, reference how SBIRT can improve the status and quality of living. And that itself is an angle that the city council may not have considered, that it's an education initiative with the other local government partners.
Absolutely. That's a great point, Amanda. I think, again, we could, in looking at ways that this impacts our communities, gosh, it's hard pressed to find an area of our community that's maybe not affected by substance use in some way, and especially our youth. I was on a call one time with Dr. Minkoff. He's a psychiatrist that does a lot of work around co-occurring disorders and things. And he made a statement one day that there isn't an adolescent that isn't affected by addiction or by substance use. And I thought, wow, that's a pretty profound statement. But he went on to clarify. He said either their peers are doing it, they're engaging in it, or they have family members who are. And I think that's a really good point, that again, the effects of this are so profound, so extensive, that really, again, if your community is looking at, again, this education aspect, it absolutely can be. Again, that SAMHSA website listed some information there about college and universities. I've seen some schools, some colleges where they've taken the information to do this more in a group setting, more as an educational, more than an individual chart kind of thing, but they do it in a group setting where they present the information, do some brief intervention, and have seen some real positive results from that. So I think as we go forward, I'm looking at the time here. We only have about 5 minutes. I do want to mention a few things. Sean, was there some things you want to specifically get to before we wrap up today?
Maybe we can address any other questions towards the end of the next webinar. If you go forward a bit, we can talk about the timing for that next webinar. On December 16th, we will be having the third in this series of SBIRT webinars from Christina. Again, I'll be following up with an email shortly about the link to stream the first one, the overview of SBIRT, if you didn't catch us with that one, and also a registration link for this December 16th webinar. And so that one, again, is about building these skills like motivational interviewing. Like, how do you work with people in a way that leads to effective execution of SBIRT, as it were. And then a little bit later, January 7th, as everyone's coming back for the new year, we're going to be having a webinar from Ashley Bodiford about community readiness and organizational capacity. So for those of us who are working, again, at that community organization level, how do we make these small nonprofits, small, branches of a government service organization, how can we connect with other organizations and, in spite of having sort of like a smaller amount of manpower, like have the impact that we intend to have on the community. So both of those webinars are coming up. We'll have a registration link for both of those webinars shortly. For now, I wanted to take the time to thank you, Christina, so much for another great webinar on SBIRT. I found it really engaging. I like the integration of resources throughout the webinar. And also take a moment just to thank all of our attendees today. Again, I'll be following up and sharing resources, so you'll see that shortly in the email today.
Okay, thank you, Sean. I did also want to thank everybody for joining us today. If you have additional questions, I would put out there my phone number as well as my email. You're welcome to give me a call or shoot me an email. Is probably the easiest way to get in contact with me. But this is definitely an area of passion for me, and I've done some work for a few years now. So love to hear from you if you have questions, or again, any if I don't know, I can hopefully get you to the right person who does. And then real quick, Sean, did you want to mention this just here to wrap up? Absolutely.
And so CADCA is a partner, one of the main partners on the Opioid Response Network project. It's one of many different projects that we work on from CADCA. If you'd like to learn more about becoming a CADCA member, please do visit our webpage and consider the information there. CADCA membership, among other things, there's lots of great learning opportunities. We make publications sort of about evidence-based prevention. And also, of course, there are discounts both to affinity program members, and then to our main conferences and training events every year.
Okay, very good. Well, again, hopefully we'll see you all. I'm going to go back here just to remind you again, those webinars coming up. We'd love to see you again, and thanks for coming today and joining us. Have a great day.